Margaret is sitting at the kitchen table when the man she has been married to for 31 years walks through the back door. He is carrying groceries. He says her name the way he always says her name. He sets the bags down and asks if she's feeling better today. She watches him move through the kitchen, opening the refrigerator, putting things away, humming something under his breath. And she feels nothing. Not coldness, not anger. Nothing that belongs to him. She knows his face. She knows his voice. She knows this is the kitchen where they have eaten 10,000 meals together. And she is absolutely certain, in a way she cannot explain, and does not need to explain, that this man is not her husband. Capgras Syndrome is a delusional misidentification disorder in which a person becomes convinced that someone close to them, a spouse, a parent, a child, occasionally even a pet, has been replaced by an identical imposter. The individual's face is recognized. Their voice is familiar. Every external detail matches. But something essential is absent, and the brain resolves that absence not with confusion, but with certainty. This is not the real person. The condition was first described in 1923 by French psychiatrists Joseph Capgras and Jean Reboulechaud, who documented a woman they called Madame M, who believed her husband and children had been systematically replaced by doubles. It is estimated to occur in roughly 1 to 4% of patients with psychotic disorders, and is also documented in cases of dementia, traumatic brain injury, and certain neurological conditions. It is rare. It is, for those inside it, completely real. Margaret was 63 years old, recently retired from a career in municipal planning, and by all accounts a methodical, grounded woman. She had a reputation for precision. Colleagues remembered her for catching errors that others missed, for asking the clarifying question no one else thought to ask. She had been married to Robert since her early 30s. They had 2 adult children, a son in Portland and a daughter who lived 40 minutes away. She gardened. She kept a meticulous household calendar. She read history. Her daughter, Claire, would later describe her mother before the illness as someone who was the most reliably herself person I have ever known, someone whose interior and exterior always matched. Margaret's first cognitive symptoms emerged quietly, almost bureaucratically, as they often do. Small memory slippages, a word lost mid-sentence, a Tuesday mistaken for a Wednesday. Her GP noted mild cognitive decline. No one was alarmed. These things happened at 63. It began not with accusation, but with distance. Robert noticed it first as a kind of withdrawal. Margaret watching him from across rooms, a slight delay before she responded to his touch. She told Claire in a phone call that she had been feeling strange around Dad lately, that something felt off in a way she could not name. She used the word hollow. She said the house felt hollow, which Claire assumed was a symptom of the retirement adjustment, of suddenly having long, unstructured days. Then one evening in March, Margaret asked Robert, carefully and without hostility, whether something had happened to him recently, whether he had been unwell. He said no. She nodded slowly and did not bring it up again that night. But she had begun, in the private architecture of her mind, to construct an explanation for what she was experiencing. The face she recognized, the voice she knew, and the complete, inexplicable absence of the feeling that had accompanied both for 31 years. Within 6 weeks, the explanation had solidified into a conviction. The man living in her home was not Robert. He was, Margaret explained to her daughter with calm specificity, someone who looked like Robert, knew things about Robert, had been placed there for reasons she did not yet fully understand. She was not frightened of him, she clarified. He had not harmed her, but she was not going to be deceived. She began sleeping in the guest room. She stopped using Robert's name, referring to him instead as him or that man. She would speak to him politely, even warmly at times, but with the careful cordiality one extends to a stranger one does not wish to offend. When Claire pushed back, when she said, "Mom, that is Dad. I promise you that is Dad," Margaret's response was patient and immovable. She would say, "I know you believe that." And she would say it in the tone of someone who has simply seen more than you have. For Robert, the experience was a particular kind of grief, one with no vocabulary and no recognized ritual. His wife was alive, she was present, she spoke to him daily, and she had placed him, completely and without malice, outside the boundary of what was real to her. He told Claire that the worst part was not the accusation. The worst part was the politeness, the way she passed him the salt at dinner, the way she thanked him for things around the house. All of it delivered from behind a glass wall he could not break through or name. Claire became the primary point of contact between her parents, translating, mediating, absorbing. She researched obsessively. She found the clinical literature and read it at 2 a.m. in her car outside her parents' house. Her brother flew in from Portland once and left after 4 days, shaken in a way he did not have language for. The family did not fall apart. They reorganized quietly and permanently around a loss that was not a loss anyone could point to. The most widely accepted neurological explanation for Capgras syndrome is the dual root model of face processing, proposed by Hayden Ellis and Andrew Young in the 1990s. Under normal conditions, recognizing a familiar face involves 2 parallel pathways. The first is cognitive. The visual cortex processes the face and matches it against stored representations, producing identification. The second is affective. The amygdala generates an automatic emotional response, a feeling of familiarity that accompanies recognition. In Capgras, the cognitive pathway remains largely intact. Margaret sees Robert and her brain correctly identifies the face. But the affective pathway is disrupted. The amygdala fails to produce the emotional signal that should accompany that identification. The warmth, the felt sense of this is him. Her brain, confronted with a face it recognizes but does not feel, generates the most logical explanation available to it. The face is a copy. The original is gone. This is not psychosis in the colloquial sense. This is the brain problem solving with the information it has. The conclusion is rational. The premise is broken. Margaret was diagnosed at a memory clinic 8 months after her symptoms began. Neuroimaging revealed patterns consistent with Lewy body dementia, a diagnosis that explained both the cognitive decline and the misidentification. Antipsychotic medications were introduced with moderate effect. The delusion did not resolve, but it softened at the edges. There were days when Margaret would sit beside Robert and seem, for a few minutes at a time, to reach him. Whether she believed in those moments that he was real, or whether she had simply found a way to be near him anyway, is something no one can say with certainty. She moved into a memory care facility 14 months after diagnosis. Robert visited every day for the first year. She always recognized his face. She was always glad to see him. Whether she knew who he was is a question that cannot be answered cleanly, and perhaps does not need to be. What Margaret's case asks us to consider is not how fragile the mind is, but how much of what we call love is neurological, a signal, a charge, a loop of recognition and feeling that we experience as something far larger than biology. When that signal breaks, the person remains, the face remains. What